have 85th lecture session organized by ECG study group, ECG Basic and Beyond. And our presenter today is none other than Professor Chowdhury Dr. Ahsan sir. Before start of the lecture session, I'd like to request Professor Abdul Jamil sir to use or say some words regarding Chowdhury Ahsan sir, and then we proceed. Abdul Jamil sir. Jamil sir, do you hear me?
Yes. Thank you, Tushar, for allowing me to say something about Chowdhury Ahsan Hafiz Bhai. And he's, so far I encountered with him, he's a great teacher. I first met him when he came for the first time in Bangladesh and did workshop in Ibrahim Cardiac Center. From that onwards, it's near about 10 years, Hafiz Bhai?
Yeah.
Or more.
Right. More. Getting old.
And every time he comes to Bangladesh, he contributes something to our subject. And in this ECG session, he always teaches us, and I learn many things from him. He's a great teacher, great clinician, and great interventionalist. So we like to hear from him now. Thank you very much. Hafiz Bhai, please.
So I don't know. Thank you, Jamil Bhai. This is a session that I'm going to dedicate only for EKG interpretation in acute situation. So it will be two parts. One is the EKG interpretation without arrhythmia, and then a second part will do in acute situation with arrhythmias. So if you look at this patient, this is a vexing problem in the United States and probably everywhere in the world, that when there is an abnormal EKG, many of the physicians feel scared in a way that, is it an acute MI? And today I wanted to tell you that the ECG is suggestive of myocardial infarction or an acute impending problem, but it never is conclusive. I'd say never, because the clinical context is very, very important. And you will see with my case examples. So 36-year-old had chest pain, and then this EKG on the left-hand side showing that there is some ST changes. Troponin came positive with the ISTAT troponin immediately within minutes, and they activated the cath lab, and the interventionalist did the cath, but the coronaries are normal. So what went wrong? Because the patient has some inflammatory problem, fever, diarrhea, and this is more of an acute pericarditis. So the troponin came in, this troponin is not suggestive of MI. How about this one? 64-year-old with 9 hours of chest pain, EKG inferior ST elevation, and you can see clearly the right coronary is occluded, and then we revascularized. Troponin came positive, and we call it acute MI, ST elevation inferior, and good outcome. And then sometimes we see this, how significant this EKG, sinus rhythm, sinus tachycardia, ST elevation in the lead AVR. This is something we worry about left main or ostial LAD. And indeed, if you look at the cath, then you see that there is significant ostial disease. And we call it MI. So traditionally and conceptually, what we know is that there is plaque formation, plaque growth, then there is this thin cap fibroatheroma and plaque rupture, plaque erosion, leading to activation of the coagulation cascade, and then the platelet activation, leading to the acute occlusion of the vessel. It may not be total occlusion, and that's maybe one of the reasons that non-ST population there is no benefit with the thrombolytics. And it is important that we make these decisions and then decide about our treatment strategy. If you look at the left-hand side, patients with non-STEMI versus STEMI, over time, they catch up with the event rate, although there is an early separation. And in both groups, if you don't do mechanical revascularization, I'm not talking about MI with no obstructive disease or MI with minor obstructive disease, MINOCA, or small third or fourth diagonal disease. I'm talking about major epicardial stenosis with presentation with STEMI or non-STEMI, where there is a significant difference in mortality. And if you look at the right, the door to balloon time and the revascularization, the earlier we can open, the best is the outcome. If you look at from 4.6% to almost 3 times more if there is a delay in the care. So it is important that we recognize these clinical entities and then work accordingly. And I'm going to now show you a series of EKGs for the sake of discussion. Take that this everybody presented with 50-year-old and chest pain. And you need to know more little bit to understand and triage the patient. This is anterior wall MI, and I call it STEMI. A STEMI has 2 parts, ST elevation and the MI. The MI part is clinical. The ST elevation part is the EKG part. And this is ST elevation in the precordial lead, ST elevation, but there is ST segment concave upwards, and then PR elevation in AVR, and then PR depression. This is acute pericarditis, like our first patient, where they presented with acute pericarditis. So perimyocarditis can give you troponin rise. This is left bundle, and the patient comes in your office. You see that there is ST elevation, there is a panic, and the patient actually was sent to the ER, but the patient is asymptomatic. This is known left bundle. And then this is another patient with the ST elevation in the precordial leads, little bit difficult, and clinical context is very important. Patient was found down, and then this EKG, and then I'll show you what happened to this patient later. And if I tell you this patient's clinical context, you would not consider this acute MI. For example, this is a 50-year-old coming with some chest pain, started in dialysis, and then fatigue, short of breath. By the time came to the ER, patient is chest pain free. But the ER emergency room called for ST elevation MI. But where is the MI part? The MI, the myocardial infarction, clinical situation does not fit in, and the EKG fits in more with hyperkalemia. Indeed, it was hyperkalemia. On the other hand, there is ST segment elevation lead 2-3 AVF and lead 1 and AVL. You can argue that this is inferior ST elevation. Is it circumflex or is it RCA? More likely circumflex. So similarly, this is a patient with 50-year-old, has hypertension, used substance abuse, cocaine, came in with chest pain. But by the time chest pain is gone, you walk in and the patient is watching the TV and or using the phone, does not look like MI behavior. And this is more likely LVH. And this is another patient with ST segment depression in lead 1 and V1, V2. And it is horizontal ST depression, positive R wave. This is true posterior. Usually these are associated with inferior EKG changes, but this is true posterior MI. So, and this is another patient from previous cabbage, comes in with chest pain, but the chest pain is only transient for seconds, now doing fine. Patient claims that he is fine, but the ER doctor is worried. This is actually cued out old anterior with anterior apical aneurysm from previous cabbage. Paced rhythm, you cannot interpret, and it is important to take the whole thing, the clinical context. This is another one with left bundle, but if you see the Garbosa criteria, you can favor in terms of which one, or you can do a echo and a wall motion abnormality, but it's tough. So what I'm trying to tell you that this is very, very important to take the clinical context before we interpret the EKG. EKG should not be something that should intimidate us, because the best thing, the only time EKG can intimidate us is probably in the board exam, because there is no patient. But otherwise, patient in front of you, and you need to make a decision about why. This is left bundle and left axis. This is right bundle, and this is severe ST changes with tall peak T hyperkalemia. And we sometimes get these kind of patients, particularly from Southeast Asia, young patient, fever, and then you see these EKG changes and they will be worried. This is actually classic Brugada, and you don't need to worry about this. So Brugada is important, otherwise you end up this patient with CAT. Now, a little bit of fever can compound the problem. Severe or massive pulmonary embolism can give you ST elevation, but this is rare because you need to see the context. They can see the coding of the patient. It will be PEA arrest, pulseless electrical activity, but not VFib arrest classically. And this ST elevation in pulmonary embolism is extremely rare. It's more rarer than the S1Q3T3, but it can happen, and it can happen with right bundle and precordial changes. But what I'm trying to say that it is the clinical context that you interpret. And then you need to worry about this biphasic T wave. It is a typical pattern, biphasic T inversions, and the clinical context will tell you what the patient is doing. However, if you look at this EKG, neurosurgical ICU patient in neurosurgical ICU because of augmentation, troponin came out positive, and this T inversion in the precordial, in the inferior leads, and also there is QT prolonged. So what will you do? Will you call it like an acute MI and go to the cath lab, or what do you do? So people get worried. So the issue is that, and I have a rule, if the EKG looks uglier, the more ugly it looks, the less likely that it is an acute ischemic event. In this patient, it was actually the intracranial bleed. So, I mean, think about this, that we should not do harm to the patient. If there is an intracranial bleed and this deep ST changes, then we should not give anything. And if the troponin comes positive, no worries for the type 1 MI. Type 1 MI is the plaque rupture, plaque erosion, activation of the coagulation cascade, and the platelet activation. Then you need antiplatelets, anticoagulation. If it is not, then we should not. And then D Winter sign, acute angle in the precordial lead. And again, clinical context, it is a patient with chest pain, 10 out of 10 chest pain, and this EKG, it is suggestive of LAD. So the D Winter sign we need to recognize. There's various forms. Hypothermia can give you pseudo ST elevations, but you need to be careful. So if you look at this, ST elevation is the part of ST elevation MI, not solely indicative of STEMI, because there are many other causes, as you all know: left bundle, pre-excitation, Brugada, perimyocarditis, pulmonary embolism. It can be confusing with hyperkalemia, subrecurrent hemorrhage. So it is always clinical context. If you look at this panel, this is published in New England Journal of Medicine. It's a must read for all clinicians. Left ventricular hypertrophy, the first panel. Second panel is the left bundle branch block. Third one is acute perimyocarditis, can be ST segment concave upwards. Then this is hyperkalemia with tall T. Then real deal ST elevation MI. And then right bundle, you can still read STEMI and also Brugada. And think about this. This EKG can be really a problem and how you treat this patient. If I tell you the clinical context of this patient, you'll be able to figure this out right away. But we were called in only last week about this patient with ST elevation MI. And when we went there, the patient is a dialysis patient, got COVID, severe hypoxia, and then also patient had hyperkalemia. But this is mimicking ST elevation MI. But there is no MI because clinically it doesn't fit in. And when we did a bedside echo, it was rather hyperdynamic LV. So the EKG interpretation in acute MI can be tricky. We need to be careful. This, and also we need to make sure that we use our best judgment to decide about what to do with the patient. I give you one example. This happened. I don't have the EKG. I was trying to put this together. 25-year-old when we went, I'm not talking about this patient. Let me hear me out, and then I'll talk about this patient. 25-year-old when we are in Sylhet, they brought up this issue. 25-year-old female delivered baby like a couple of days ago, and now developed chest pain, severe chest pain, diaphoretic, blood pressure dropped, and ST elevation in the precordial leads. And the patient is not able to get access to the cath lab. And there was a question about whether we should be giving lytics to that patient. Any suggestion from the faculty whether we should give a lytics to this patient?
I think, sir, this is a SCAD, part of a SCAD.
Okay.
Possibly.
So this is important, right? To think about pathophysiologic mechanism. I think I would not give lytics on a 25-year-old who just had a baby delivered, and because it will be doing more harm. And the pathophysiologic mechanism is not type 1 MI. Similarly, this patient, 86-year-old, 86, he was found down, and then troponin came positive, and then this EKG, and they are thinking we should give lytics if you're not taking to the cath lab. And I said, no, I'm going to take to the cath lab. But my question is, the ER attending is saying, if you're not going to the cath lab, I'm going to give lytics. I said, why you are going to give lytics? You don't know what's happening here. So to cut this story short, we did a echo first, and I have published also with others that echo can be of helpful, because MI patient suddenly getting obtunded mentation and found on the floor, and when you reach there, heart rate, blood pressure good, I mean, it raises question, right? It doesn't fit in. Why suddenly the patient will be losing consciousness? So something else happened. So this is the angiogram. You can see very good flow throughout the left system, left dominant, and then there are no flow limiting stenosis and no infarculated artery. And then when we did this, it's non-dominant right. And then when we did the echo, this is classic Takasubu. Question is it not better that we take the clinical context and don't panic, and then figure out what is the most likely thing and take a comprehensive view about what to do next? And this is, it is not difficult to figure this out when you see this kind of bedside echo, that this is most likely STEMI, and then it is more consistent with that. This is when we published this in 2005, that echo can be helpful. Now we have even more evidence by looking at the definitive or contrast echo, which delineates the LV function much better. So what I'm trying to tell you, that the troponin can be positive, troponin will come positive, but question is is it the type 1 MI? If it is not type 1 MI, then there is no point in giving antiplatelets, anticoagulation, or for that matter, even worse, giving thrombolytics. So EKG has to be read in the clinical context and use our tools. So what is then the definition? And what about this Takasubu? So this is either an epinephrine-related sympathetic surge or inflammatory surge or serotonin surge. These are the reason why the troponin goes high and there is some kind of myocardial stunning, giving a typical pattern. These are not type 1 MI. These are not type 1 MI. In fact, this is not MI at all. And I'll tell you why. Because it is an inflammatory changes. And I'll show you that there are many pathways for this. So what is then the definition of MI? Hypoxia or hypoperfusion related myocardial damage. Hypoxia, hypoperfusion, if it is with plaque rupture, plaque erosion, platelet activation, and coagulation activation, that is type 1. But if it's type 2, which is readily explainable by COPD exacerbation and hypoxia, that is type 2, or anemia, hemoglobin 5, or for that matter, it is not the other causes in terms of tachycardia and hypoperfusion, that can be type 2 MI as well. And we see that all the time in a SVT, AV nodal re-entry TAC, and small troponin. So 85-year-old who was found to be at home, there was carbon monoxide poisoning, and EKG showed ST changes, troponin came positive. Is that MI? Anyone from the audience? Carbon monoxide poisoning and troponin positive, and the burn resident is asking us, should I give aspirin, heparin? And are you going to take to the cath lab? So this is
I think so probably no, sir, because this is a global hypoxia, not
Yeah,
a
but
obstructive lesion.
Not about global hypoxia, but by new definition of MI, sir, that raised troponin with myocardial injury.
right.
That may be
So this is
due to anemia, that may be due to monoxide poisoning, that may be due to thromboembolism. All are MI.
right. So I would request the audience to carefully listen to Professor Ashok Doctor, how nicely he's saying that the mechanism of the MI is important to understand. And this is hypoxia related to MI, but it's type 2 MI. And why it is important? Because for that reason, you don't need to antiplatelets, anticoagulation. You just treat the underlying cause. 29-year-old brought in by, I don't know why I'm getting echo. 29-year-old coming with the EMS, unconscious, and the troponin came positive. And is it MI? After motor vehicle accident?
This is a questionable thing, because many patients I have seen in vehicle accident, troponin is very, very, very raised. When I was in Saudi Arabia, but echo was normal, ECG was perfectly normal. So this is very much difficult to explain that troponin is coming from the myocardium. I think when the other necrosis, even muscle injury, skeletal muscle injury, huge skeletal muscle injury might be a cause of troponin I raised, maybe 10, 20 like this.
So when there is a readily explainable cause for troponin, we need to take that into consideration. Look at this. I gave the example for 29-year-old following motor vehicle accident, who became unconscious. The readily explanation is that it is a trauma related. If it is trauma related, that is no hypoxia, no hypoperfusion. So this is traumatic injury. As we remember from pathology book, myocardial injury will lead to myocardial necrosis. What is the type of injury? Is it toxic injury? Is it inflammatory injury? Or is it hypoxic injury? If it is hypoxic injury, then only we call it MI. If it is not hypoxic injury, traumatic injury, we don't call it MI. And it doesn't matter, whatever EKG changes is there, we will not give this patient troponin, antiplatelets, anticoagulation. Particularly, we need to be careful that motor vehicle accident is anterior, the shear injury, right ventricle may get little injury, and there may be even pericardial effusion. So it is very important that blunt injury can give you this kind of problem. So cardiomyocyte and troponin relief, there is a variety of reasons that can give you the troponin rise, and then that can give you the problem. So it is important that what we have done in the troponin world and defining MI, we need to understand the clinical part, the EKG part, and the troponin part. The troponin part, my 2 cents to you is that troponin has gone through a revolution in terms of how we assay the troponin from 1st generation to now the 5th generation. We have made the 5th generation troponin highly sensitive to pick up, but at the cost of the problem that the specificity without the clinical context can be a problem, big problem. So the troponin, I will tell you 2 things. One, the temporal change of troponin is very important. Is it 20% change or 50% change within 3 hours? And does the clinical context help to define? And more importantly, do you have any other explanation for the troponin rise and fall? Particularly, I do not want to see that you are giving blood transfusion in one hand and then heading to the cath lab for a cath when the hemoglobin is 4. This is very important to understand that clinical context is very important to decide what type of MI we are talking about. So this is sensitivity at the expense of specificity. The 5th generation troponin, we just divide by 1,000 and we get the previous kind of things. For the sake of time, I'm going to skip through quickly, but I want to show you this important slide that how the 5th generation troponin correlates with the older generation troponin. But the magnitude, we put the upper reference level and then we call this sensitivity and specificity. But and in the COVID time, it was eye-opening because a variety of reasons can mimic the troponin, and the anxiety and the reluctance of taking to the cath lab actually helped us in many ways. We saw a higher number of Takasubu. We saw a higher number of type 2 MI. Even EKG was helpful. We are able to tell that this patient is COVID by looking at the EKG. Shoulder down ST elevation, hypoxia, and then hyperkalemia, and also prognostic implications. And using of ultrasound was helpful. But a small cohort of patients with type 1 MI or even thrombotic events in COVID time, we said give lytics and then do not take to the cath lab. Such a wrong move because it did not work. And we ended up taking to the cath lab. We actually never stopped taking to the cath lab. In any case, this is very important, and I'm not going to bother you with this, but everybody needs to read this about the types of MI. But let me give you some examples, and then we'll come to a conclusion and leave some time for discussion. 41-year-old, altered mentation, Glasgow Coma Scale 3, and then this EKG. And this one actually is good for Atahar Ali. So the patient came in and then tachycardia, narrow complex tachycardia with ST changes, and they called us for a STEMI. And in fact, the ER physician played smart, saying that, don't you see there is a AVR ST elevation and then ST depression globally? This is left main. And I said the clinical context doesn't fit in, because a 41-year-old with left main multivessel, but why the patient is unconscious, and Glasgow Coma Scale 3, right? So we gave adenosine, and then the EKG came like this. When the EKG came like this, with the AV nodal re-entry TAC responding so well, I don't think that there was any reason to rush to the cath lab, because it was evident that this was all tachycardia related ST changes. And then you, even to convince the ER physician and convince yourself, you can do more EKGs, troponin, but that will be it. Any comments so far?
Sir, there was something.
Last ECG after conversion of the tachycardia is quite normal. So we are confident likely that is ST wave change related to the tachycardia. But many patients after SVT, we have seen that there is some ST wave change for next 24-48 hours. That is the memory. And in this situation, what we will do?
Say that again. Sorry.
Sometimes after tachycardia converted to sinus rhythm, memory T wave change and sometimes ST depression persists for a few hours or even 24 hours. So in that situation, how we will decide that this patient does not need cath?
Okay, so first of all, if there is a T wave memory, right, there is a persistent T inversion takes time. But the question is, if there is no ST elevation, clinical elevation, we always emergency room physician convince yourself that ST changes is reversible with the tachycardia management. So the pressure is off. And then you look at the T inversions, you can follow the 3 hours troponin change. And then I'm going to show you next that what that will tell you, and also use the echo. This patient's echo, transmyocardial injury from acute thrombotic occlusion. Usually you see wall motion changes. This degree of problem. In the case of non-STEMI, you may not see. So in this case, we did not see any T inversions, but even if we did, we would not take to the cath lab because it does not fit in with the overall clinical picture. And then we actually did the patient also. If I tell you the patient, it was summertime and the temperature was high. Okay, look at the temperature. Patient's temperature was 106. So the clinical context is very, very important, that how you decide. And the ECG after cooling, no change. And then this, we get this few in the summertime, particularly when there is the music festival. And then we see a couple of patients like this. We have many of you visited Las Vegas. This patient came in from Caesar's Palace. He was waiting for the cab and then became confused and tremor, and then this EKG. Initial EKG, tachycardia, white complex, maybe there is LVH. Troponin came positive. And then what you do now? See that EKG from B to B3, but look at the temporal change in troponin. Anterior wall MI, if it is type 1, the troponin rise should not be that. So this was reassuring because I deactivated because the clinical picture was not feeding in and the cocaine came positive, blood pressure was really high. So it was, double product high along with the troponin. This patient, 80-year-old, the found down, and the patient was, there was feces and urine in the floor. So does it sound MI to you? But we are called in because of the ST segment changes. And we did not, of course, take this patient to the cath lab. Troponin did go up, but I'll show you that when the troponin goes up, the binary definition, troponin positive, negative, is important. And you need to look for the cause of the troponin. But look at the magnitude of the rise. After 50,000 or 50 by your fourth generation troponin assay, and 50,000 by the fifth generation, only myocarditis and large MI, it becomes less and less differential. And then small troponin less than 5,000, and I call it less than 5. And then mini troponin, I call it less than 1, but positive. Less than 1 can be challenging. It can be mixed bag. It can be very non-ST elevation MI type 1, or it can be type 2 MI, and it is a mixed bag of a diagnosis. And if you have a readily explainable cause, then that is probably likely the cause. But if it is not, and the clinical picture, the scenario, chest pain, short of breath, angina equivalent, and dynamic EKG changes, all indicative of, then that small troponin can be the tip of the iceberg of a true type 1 MI. That I'm trying to say. But if there is readily explainable cause, severe hypoxia, PE, or COPD, asthma, severe anemia, and then in some cases, clinical situation will tell you that what is the underlying pathophysiologic mechanism. And we did that. We looked at the troponin. At that time, it was older generation. When it is more than 5 versus less than 5, more than 5 troponin, you take them to the cath lab later after stabilizing the patient, then there is more likely of underlying significant, hemodynamically significant coronary stenosis. So this is EKG of someone that I showed you, that the patient was found in mixed with feces and all that. And then the troponin was 5,000, and it was respectable troponin. We recovered the patient. LV function I showed you was normal, and we did an old coronary disease, and doesn't explain the patient's clinical situation, which was because of the medication overdose and not because of the acute MI. So this is very important, that the troponin binary definition, positive, negative, with the clinical scenario and the EKG to interpret, but also the magnitude of troponin, as I told you, it has importance. So if the EKG changes, maybe that we fail to recognize, and the troponin rising way too much, particularly I see that often with diabetic ketoacidosis, hyperosmolar diabetic, and we have a lower threshold. If the troponin is 10,000 or 10, 5,000 or 5 or more, to do the cath on those patients, because they have probably more hemodynamically significant coronary disease. So this is troponin level and outcome. I don't think that it will surprise you. The higher the troponin, and then clinical context suggestive of type 1 MI, non-STEMI or STEMI, the prognosis is universally worse in those group with the higher troponin. So this is another important thing, sepsis. Remember, in the sepsis situation, and I am spending little time on this because COVID opened our eyes. There is many factors, as I discussed, can interplay. In sepsis, there can be just inflammatory toxic injury. In a 29-year-old female with the sepsis picture, that is more likely. But in a 70-year-old with UTI and sepsis, it may start with inflammation, But as the sepsis progresses and causes hemodynamic problem, then it may be compounded with initially toxic injury, no MI, but then hypotension, hypoperfusion, and then hemoglobin dropping because there is a bleeding also started. Then it can be really messy and can be type 2 MI. So in this case, it is very important that we need to pay attention. But sometimes we are confused, and in the United States particularly, documentation is important for reimbursement purposes and payment, not only the harm to the patient. Patient coming with lap chole, and then following lap chole got atrial fibrillation. After atrial fibrillation, there is high sensitive troponin became positive, and then they wrote MI. And that became a problem because you'll have to define that this is small troponin atrial fibrillation and tachycardia related, and not the classic hyper, the plaque rupture, plaque erosion, platelet activation, anticoagulation activation, and type 1 MI. It is not, most likely. And then you write that. And if the patient is behaving like AFib got better, patient feels better, troponin is small, EF normal, then it's most likely that this is type 2. We are not God, and we don't have crystal ball. We may not be able to define everything rightfully, but we need to be practical. We need to be pragmatic in terms of when we tell the patients about the classic MI, I am trying to mean type 1, or it is type 2. Sometimes you do this test like troponin and over enthusiastically call this MI classic, and the patient gets worried. And sometimes we may putting ourselves in more trouble doing harm to the patient when it is not necessary. So it is important that we look at the EKG, look at the clinical context, look at the dynamic EKG changes, try to understand the morphologic changes, and then see, does it fit in with anything else other than the classic ST elevation MI? Either by EKG, I gave you a variety of reasons why the patient can be ST elevation. Early repolarization is another thing, particularly more common in African American. Early repolarization, LVH, transient ST elevation, coronary vasospasm, then left bundle, hyperkalemia, in rare cases, pulmonary embolism, Brugada, or old anterior ST elevations from the persistent ST elevation from LV aneurysm. A variety of reasons. You know all of this. You know all of this. You have read this. But when we look at the EKG, for some reason, I don't know. This is my observation. We get intimidated and we jump with the STEMI diagnosis, not looking at the clinical context enough, because this is important. So this is another patient, 36-year-old. I think I gave you this one, and I'll probably finish with this note. This is 9:24, almost like an hour, and I really want to make some discussions because there is some concept issue here, so we can have some discussion. So to read the EKG is important, is clinical context, and then I think the more we are looking into this, more data, it is helpful. Like troponin is helpful, but it can also misguide us. Bedside echo is helpful, but sometimes it may also misguide us. So at the end of the day, it is important that we pay attention to the safety of the patient. And everything we do in medicine, we need to take into context that, well, if that is the working diagnosis, and this is my management strategy, is it going to do more benefit to the patient than harm? And then you decide. Thank you.
Thank you very much, sir. Thank you very much for this time-demanding and most crucial lecture regarding troponin I and the clinical context.
So now it is open for discussion. Tushar.
Yes, sir. So I have a question to Chowdhury Ahsan, sir. Sir, can I ask you a question?
Yeah, sure.
So many a times what happens that a middle-aged man with chest discomfort, not chest pain, chest discomfort with tachycardia, who comes to ER and the ER physician send the tropi and the tropi gets slightly raised. The confusion and the problem arises then, because once the tropi comes positive, borderline or slightly raised, you can't readily get the patient discharged from the emergency room and can't even also start cath procedures at the same time. So then the problem of admitting and treating the patient comes. So what's your advice to those cases?
So if it is sinus tachycardia, then that is the arrhythmia I get really more worried, because why there is sinus tachycardia? Is there any acute coronary syndrome going on and there is LV dysfunction and sinus tachycardia? Or there is readily available explanation, such as patient is febrile, have cough, pneumonia, or the patient has a belly pain. When you look at the chest discomfort, but you examine, you see that the interpretation was wrong. It was like acute cholecystitis or acute appendicitis, and then it is obvious. But there are other arrhythmias. Question is, we had patients with VTAC, sustained ventricular tachycardia monomorphic. If it is polymorphic, you always wonder whether this is associated with long QT or is it polymorphic VT with ischemic substrate and patient is having chest pain. This is another big issue. On the other hand, if it is just, as I showed you, young patient, avinodal re-entry tachycardia, and then you do the troponin, but then you need to confine the patient 3 hours after the initial, and the magnitude of the troponin rise is small and LV function good, and the patient's chest pain discomfort with the tachycardia, if that is your theory, and now better, we can negotiate with the patient that, okay, you are feeling good, most likely okay, then you just follow up the patient next day. With the shared decision making, the patient have chest pain again, come back right away. You can also make the patient walk in the hallway 10 minutes with the normal rhythm and see whether the patient is good or not. And then that will help to risk stratify. But what I'm saying, when there is a readily explainable situation, then you feel more comfort. When there is readily explainable acute coronary syndrome, and it's still after the ST segment coming back to normal and still having chest pain, you cannot send the patient because there is something underlying, and that may have triggered. So it is a tough call, but we take into consideration the totality. And one of the best thing is that rather than telling the patient that you have a heart attack, we should wait. We should say, we have sent the biomarker, the biomarker is positive. We are not sure that this is with the arrhythmia that you had, it was from this, but we are waiting for another 3 to 6 hours. We don't need to tell the patient everything at 0 hour. And trust me, patients do understand. They are knowledgeable. They understand that doctor is taking time to figure out what is going on here. But what the ER doctor says after the troponin, you have a heart attack, I'm calling cardiology. And that becomes a problem.
Chowdhury?
Yeah.
Sir, I have an experience regarding this issue. Actually, sometimes it is not only the patient's safety, sometimes our safety is in question. Sometimes we face such a type of problem that the patient is in ventilation, possibly because of the neurological cause. The troponin is raised, several, not only in the range of 100, 1,000 sometimes. The already diagnosis is made in the, that is the diagnosis sheet is that the non-STMI. Then they actually called us for the decisions of what to do. Patient has got the history of the previous stenting. So what to do in this situation? I'm clearly understanding this may be the type 2, that is the MI. But
what you just told me, that makes me little not so sure. If the patient has previous stent, that means patient is known to have coronary disease,
Right.
and the magnitude of the troponin in thousands, then remember the AV nodal reentry tag or AFib, the troponin is mini troponin, small. These are not like 20,000 troponin. When there is 20,000, or in your lab, fourth generation, maybe older generation, 20, that is a big troponin. So if it is mini troponin, and you can readily explain with the tachycardia and the temporal change, the next 3 hours is small, less than 20%, you are probably not dealing with type 1 MI. You are probably dealing with type 2 MI. But if it is thousands and the temporal change is 3 times 300% rise, and the patient is still having chest pain and or previous stent and CAD, then it's probably something underlying. And the other thing you can do, you can just say, even after 3 hours, you can say, still unclear, and you want to confine the patient, particularly if the patient is not doing well, then you confine the patient. And then you wait next 24 hours, or sometimes we even decide after the angiogram. If there's a culprit, then we call it that it is type 1 MI, and we treat that way. But in the more likely, for example, the patient that you told me with the thousands in troponin, and even if the arrhythmia, most likely underlying, and if there is no harm, hemoglobin okay, platelets okay, then we will give antiplatelets, anticoagulation. It's at some point, it is going to be some risk-benefit calculation as well, and we may not be 100% sure.
Hafiz bhai,
Professor MD Azul sir,
I can add, not add, actually discuss regarding Tushar's point. Tushar, what you will do actually in that particular case, you should go for heart score. Chest discomfort, marginally elevated troponin, score 1, chest discomfort 1, sinus tech, less than 3 heart score. So you can observe in emergency, otherwise you can discharge as well. But you should discuss with this patient party. If you need for second troponin, you can observe, keep the patient in observation in emergency department. Then if you got the second reading of troponin, if it is not rising, then you can discharge easily. Hafiz, do you agree with me?
Well, yes or no? Yes, because heart score is very good tool. But no, because if you are an emergency room doctor, then heart score is good for you to decide whether to discharge or not. But if you are a cardiology physician, then we need to go beyond, right? Because heart score is kind of a screening tool, but sometimes it may not be that obvious. The heart score, one problem I see, it does not take the absolute value of the troponin in the consideration. It does take in some way the troponin value binary way.
No net.
I think sir has disconnected from the.
আমিও বোধহয় ডিসকানেক্ট হয়ে যাচ্ছে, মাঝে মাঝে অফ হয়ে যাচ্ছে।
না, এটা স্যার ওখানে প্রফেসর আজিজুল হক স্যার, do you want to say anything?
তুষার, আমরা ডিসকানেক্ট হয়ে গেলে ওই ব্যাক অফ অ্যাপোলজি, হ্যাঁ?
No, sir. Professor Azul Haq, sir.
Hello, I'm Dr. Aziz, consultant cardiology, Glenville Hospital, UK. I'm not Professor Azul Haq, I'm another one. No worries. See, I have a comment about this one. The way they have explained the troponin, everybody should know this one, despite there is a differences there among the cardiologists. I want to share my recent experience. One patient was admitted in ICU with sepsis, ESRD on dialysis. Troponin is around 4,000. This is my maybe second time in the experience about the same patient. So what I told, this is a type 2 MI clearly, and we are not going to do anything. What happened, this sometimes our colleague makes problem. Next day, another consultant will see the patient and they will say, okay, I'll take in the cath lab. So he took the patient in the cath lab and they showed the LED 70% lesion. Fortunately, I was there on the time in the cath lab and I said, this is not a, this is a stable plaque lesion, is not a acute cause of raise this one. And there was argument. I said, okay, I will do the IVS. I did IVS and show that there is no thrombus. So sometimes this type of patient, we make a problem. We diagnose as a type 2 MI, but sometimes our colleague do this one. And once you do the stenting, the other people will say, oh, okay. So you said this type 2 MI, but the other said it's a type 1 MI, then they stented. So always there will be some dilemma, but the sir, as the way they explain, we should follow everybody and should keep in mind. So some experience will help us like this way, what I shared.
Thank you. Thank you.
Yes, Dr. Aziz, that is actually a good example. We sometimes face the same condition. Patient having complete heart block, long pause, troponinized raise. Then before doing the pacemaker, we have seen that there are what lesions in the LAD, RCA, all are borderline. So we don't have any facility to either. Suppose we have to do the pacemaker. During pacemaker implantation, where just we usually check the angiogram. So at that circumstance, what we should.
Ashok, you got muted.
I think the network is a creating problem for most of the places.
Network is disturbing.
Network is problem.
USA network today is drop down.
So I think you did not. I was not audible that time. Yeah.
Yeah. Yes. Can you say just again say the your comments regarding that complete heart block and the
Troponin I raised borderline lesion like that of the what Dr. Aziz was telling. Borderline lesion during angiogram. Just usually is when it is more than, we used to do the angiogram when we do the pacemaker. So such situation we don't have an opportunity to do the IVAS because that is costly as well as not available in most of our cath lab centers. So how we should manage? Usually most of the cases, if the patient is asymptomatic clinically, I usually avoid the condition to any PCI or anything else other than medical management.
Actually, Ashok, but I think if you have borderline lesions, if you have the facility to study the physiology of the coronary with the pressure wires like FFR or IFR, that will help to decide whether to stent or not those lesions before device implantation. If it is significant, then stenting should be done first, then go for device implantation.
Other than acute coronary syndrome, most of the cases I have seen, even severe TVD, patient was not on antiplatelet for few days. Patient was not in acute coronary syndrome. I usually put the device first. After 7 days or 10 days, I used to do that.
In that case, one thing happens, that is when you put the device, heart beats faster than previous, and in those cases, angina unmasked. So
Yeah,
you have to go for stenting.
That might be the condition. That might be the one situation. But anyhow, the synchronization sometimes improves the coronary flow.
Yeah.
Synchronization that improves coronary flow. That is a positive side of putting that dual chamber.
Yes, sir. We can also manage the problem if we keep the programming in VVI or DDI mode, so that the increased atrial rate doesn't
You
create
can give the
problem.
beta blocker. If the patient is okay,
Or
you can
beta
give beta
blocker, or
blocker.
we can give beta blockers also.
Not even okay, we can
Yeah,
give
yeah.
insulin also. So rate control is not so much difficult in itself.
Now, if there is history of paroxysmal AF, then mode switch should be on in that device, so that when it goes faster, atrial fibrillation with faster ventricular rate, so it will go for only VVI.
But in general, if sorry, I got disconnected. If you have a patient with right coronary ischemia giving significant bradycardia, demanding pacemaker, is not that common. It is always the infarct, right coronary infarct is the problem.
Not
So-
only the
so-
infarct, sir, actually the acute infarct,
Exactly.
not even recent,
Yeah.
not
Yeah,
even
yeah.
recent.
Exactly. So therefore, if it is a 60-70% mid RCA, and you are thinking that that is causing this, usually not, that is the case. It is a separate issue with the rhythm.
Yes, sir.
Sir, Assalamu alaikum.
Yeah.
So I have two queries to Ahsan sir. So my first query is that we know that pericardium is electrically neutral.
Yeah.
So in case of acute pericarditis, how do you explain the global rise of ST segment elevation?
So the most likely explanation is that there is acute perimyocarditis. So
Exactly.
it is just not the inflammation.
Exactly.
So if you look at the EKGs, when there is a injury pattern, and then if you follow them with the troponin, it is rare that the troponin did not go up. Usually
Yes,
go up. When
exactly,
there is
exactly.
a troponin rise, there is a myocardial injury.
Myocardial injury. So if we get ST segment elevation and we are suspecting it to be a case of acute pericarditis, we must think that there is something wrong beyond myocardium, and it is pericardium. It is subpericardial, that is myocardial. So in the textbook now it's referring that don't go on telling or putting or labeling it as acute pericarditis unless and until you have assessed it very well, and you have also gone for the biomarkers and you have excluded that this is not a case of acute coronary syndrome. So there is no way to call whether this is a case of acute pericarditis or acute coronary syndrome, and unless and until you have gone for the biomarkers. Because even acute pericarditis can present typically with clinical presentations mimicking that of acute coronary syndrome, and on top of that, acute pericarditis can be localized so as it can mimic that it is following a particular arterial territory, and in that case it will be very difficult for us to differentiate whether this is acute pericarditis or acute coronary syndrome. So that was my question. So acute pericarditis can even present to us without any ST segment elevation if it is solely involving the pericardium and not involving the myocardium, as we know that the pericardium is electrically neutral. So that was my first query. And the second query is, in the ECG you have shown narrow complex tachycardia. There is ST segment elevation in the AVR and ST segment depression, global ST segment depression. So you were rightly saying that ST segment depression could be explained by tachycardia or tachyarrhythmia, and it is because of the supply and demand mismatch. But my question is, as far as my knowledge is concerned, that whenever you find ST segment elevation in the AVR and ST segment depression in 7 or more leads, you should strongly suspect it to be either left main or proximal LAD. So in case of tachyarrhythmia, the ST segment depression can be because of 2 or 3 reasons. So first reason is that is tachyarrhythmia mediated supply demand mismatch, And the second
Okay, so
reason is
I got your
that,
questions. Okay, so
yes,
let me explain. So what you said, I have acknowledged that in the lecture as well, right? And the book also
yes,
says it can be complex. But what I'm trying to tell you that it is all about clinical context. So if somebody has this 29-year-old with fever, chills, and then EKG, ST segment changes, and we are debating whether this is a STEMI, ST elevation. We are not arguing about ST elevation. We are arguing about, is the ST elevation explainable by MI or explainable by acute perimyocarditis? If it is explainable by acute perimyocarditis, then the therapy is different. So there are many causes of ST elevation. Now, so that is the answer to your first question. And then remember that the acute perimyocarditis can be complicated also, because the clinical features of myocarditis is what? How somebody presents with myocarditis. Most common presentation is palpitation, tachycardia. But if it is a giant cell myocarditis, it can present with VTAC also. And you can be fooled. Is it due to the ischemic substrate that this is VT, or is it an acute myocarditis? And again, it will all depend on the clinical context. It is easy, somebody rising with the fever, 103, and it comes in the board often, that 103 temperature, and then recurrent non-sustained VT, febrile, and then this will say, what is the most likely diagnosis? We cannot be 100% sure on anything, but I'm trying to tell you that it is the clinical probability what is favoring one diagnosis over the other. Now, about the tachycardia. The tachycardia, yes, it is probably due to the subendocardial ischemia giving the ST changes, but the pathophysiologic mechanism is not acute plaque rupture, plaque erosion, activation of coagulation cascade, or platelet activation. It is probably demand-supply mismatch. And then when you restore that, the changes go away. It may not go away. Patient may still have lingering chest pain. There may be more complicated issue. A 75-year-old with AV NRT and 70% left main presented like that, and then you get it better, but it's still having problem. Then you need to figure out that why the pain not going away when the heart rate is 60. And now you have another problem that troponin rising is really high. And another problem that LV function not normal. Then you add up. But the initial assessment, you have a working diagnosis, most likely diagnosis, and then you have a differential diagnosis. But I'm saying that when it is easily explainable, then go for that, rather than invoking other diagnoses, which particularly in some setting can be misleading. Does it clarify
my confusion here was that is it usual for a tachycardia to produce that degree of ST segment depression? Because if you look at the ECG, it's 2 or more than 2 millimeter of ST segment depression globally.
Yes, it is possible. And I tell you, in another cohort that is even more possible, which is the patient who has LVH. Those patients who have LVH and they go into tachycardia, they have even more problem with the EKG changes. The afterload increase can changes the LVH EKGs. And we see this because we are lucky in a way that we have a cohort of patients with cocaine and methamphetamine. When they come in and their blood pressure is hugely elevated, and we see that, double product, which I mean, as you know from the exercise lab, double product is defined by the heart rate and the systolic blood pressure. And when the double product is very high and there is a baseline EKG, the changes can be really worrisome to you.
I totally agree with sir, 100%. Sir. I can give an example also for the audience who asked the question. Recently, I have a patient with atrial fibrillation with positive AVR with same type of ST depression. Junior was panicked, emergency, they activated the cath lab. So they called already the patient on the table, they called us patient on the table. Anyway, it is another issue. We went there, we did angiogram normal. Finally, it came out, it is an aortic dissection after echo. So say the patient was, main clinical context was palpitation and mild pain, palpitation and hypertension. So as you said, in LVH, it can give more ST depression and positive behavior. So this is a clear example of truth. And we are making publish, and already we are publishing the cases because on the context of echocardiography can help us to detect in the emergency to aortic dissection.
When I train my fellows, I said triple rule out. And then there are 5 bad causes in the emergency room, right? One is dissection, MIPE, and then pneumothorax and esophageal rupture. Pneumothorax is very easy to figure out. Esophageal rupture is almost rare. And then only thing left is 3. So PE, and then you look at the clinical context. And the EKG has to be interpreted with the EKG, with the clinical context. With the double product so high, nobody in our hospital goes to the cath lab without looking at the chest X-ray and then pressure on both sides and a bedside echo, particularly transthoracic, because what you need to rule out, descending dissection, if you miss, is more forgiving than an ascending dissection. And a root assessment and a pericardial effusion assessment is pretty easy to do. But if you have any doubt, we just do a CT chest with contrast. But absolutely right. Yeah. So it is very important. Clinical context, clinical context, clinical context.
Actually, sir, we went for echo beds on the table to rule out PRV strain. Then it turned to a severe AR and dilated root dissection.
And I tell you one thing, acute PE, massive with hemodynamic problem, usually you will see hypoxia. And and also echo is good to look at the RV, but the clue is that the acute PE does not give you severe systolic hypertension, such as 250 systolic. It does not.
I agree.
Particularly massive PE.
Rather, the hypertension will be sometimes.
Correct. Yeah.
Yes.
Really, Hafiz, actually, this message is very important as because most of the time we see that is, we understand, but it is very much difficult to convince myself that it is due to the tachycardia. Most of the time, the tachycardia patients are referred to us after doing the angiogram, having the normal findings. So it is difficult to control ourselves, that is, we should not see the coronaries. After seeing such a type of ST depression, it is usual our practice to see the coronaries, as because it is so much easy test. So this is really.
And sir, more difficult when the relation is borderline.
Really.
60-70%. Then really not explaining, but somebody will be scared and like this.
And the situation becomes complicated when incidental there is a findings of some borderline lesion.
Yeah.
And I will tell you this. I'm sorry that my presentation may be more confusing to some, but I will tell you one thing. Once you grow older and you become more mature and experienced, you will probably realize more what I presented today.
Exactly, sir. Definitely.
So if you are young and you are asking questions, please continue to do so. Please challenge your attendings or faculty. Ask questions and differ with the attending. And I tell my fellows will argue with me. How come you said this? And I said, okay, I'm listening to you. Yeah, it is in my differential, but I'm prioritizing which is more likely here. So please do fight. Do not follow your attending or faculty. Ask questions. Put your thought. Try to find out why the decision was made. And that will make you better.
Thank you, sir. Thank you for excellent discussion and the presentations. I'd like to request Professor Atahar Ali, sir, to say some discuss about the whole presentation and his views regarding the presentation.
Now, really, Tushar, this was a really outstanding lecture, and particularly this is the real, that is the daily life problem, real life problem, that is type 1 versus type 2 MI, and how to differentiate and how to interpret the troponin in the ECG, and what is the importance of clinical context. This was the message of this lecture today. There is no hard and fast rule, and one important thing is that we must not be dogmatic about the level and that is the cutoff value, that is, this is the number 3, this is the number 4 library. It is a whole scenario, that is the clinical situation, presentation, patient's profile, and then the ECG changes and the troponin. This was the message of Dr. Hafi's lecture. I think this was a very great lecture for today's session. And in this situation, really, we face the daily life problem, that is the high troponin level, what to do, high troponin level, what to do, and incidentally there is a some kind of the bystander lesson of what to do and which one is that. This is sometimes become the legal problem also in our daily life practice. So excellent talk and very provocating talk. Thank you very much, Chowdhury Hafiz, and congratulations to you. And another important message to this forum is that Chowdhury Hafiz and Dr. Aziz also, and Dr. Zaman, and our Ramadan month is coming and it will start soon. So this session, that is the ECG study groups, this ECG program will remain, that is the closed during the Ramadan session, and our session will start again in the after the Ramadan in May. And at that time, Dr. Azizul Haq from USA will our speaker. He has already declared that he will give this talk to in that day. So I think very good discussion today, and thank you very much, and welcome Dr. Aziz from UK for participating in this session, and Dr. that is the Chowdhury Abdul Wadud Chowdhury, you are here.
Sir, is still in the cath lab, I guess.
I'm still in the cath lab. So we can conclude the session, and our next session will be in the May. And Abdul Al-Zamil, you can conclude the session.
I like to give a special thanks from my side to Chowdhury Ahsan sir. I don't know how much others are benefited, but I have greatly benefited from his lecture.
Really?
Otherwise, আমি মাঝখানে থাকতে পারি না. I was a guest came, so please wrap up the session.
না, আমাদের অশোক দত্তের মতে রিয়েলি অ্যাকচুয়ালি আমরা সবচেয়ে বেশি বেনিফিটেড হয়েছি. আমার মনে হয় যে এই ব্যাপারে কোনো সন্দেহ নেই. very useful and informative and wonderful provocating lecture today. Chowdhury Hafiz, thank you very much and congratulations. He is not in the screen. So Tushar, we can conclude the session.
ওখানে নেটওয়ার্কের ঝামেলা হচ্ছে.
Tushar,
conclude করে দেন.
Yes, we can leave and we can conclude the session. Thank you very much for participating.
Thank you.